Welcome, everyone. My name is Michael Walsh. I'm an adjunct fellow at the Center for African Studies at Howard University. Today, we're here to have a conversation about the future of emergency medical team response in Sub-Saharan Africa, looking at opportunities and challenges with Dr. Thierno Baldé of the World Health Organization. Dr. Baldé, welcome to the program. Can you please tell us a little bit more about the work that you do and the WHO does in Sub-Saharan Africa with emergency medical teams?
Thank you, Michael, and thank you for the opportunity. And good afternoon, colleagues. My name is Thierno Baldé, and I'm calling from Brazzaville in Congo here, where we have the regional office of WHO Africa. We do cover 47 countries of mostly the Sub-Saharan African countries, and so I'm part of the emergency team here in the regional office of WHO, and we are also the one in charge of leading the rolling out and the implementation of the emergency medical team in Africa. I've been working on this subject since 2017. You know, the emergency medical team started in 2000, somehow 14, 15 at the global level, and with a regional implementation which started in end of 2017. I don't know how far you are familiar with the concept of the emergency medical team, but it's usually a group of health professionals which are somehow organized and deployed in some kind of crisis, for providing direct care, to the affected population by an emergency. So that word of direct care, clinical care, it's quite very important because it's really people who are coming, with some kind of materials and equipments, to go in an area which is affected by an emergency and to provide that care, to the people. And there are different levels of care which are provided by different emergency medical teams. Usually we have three types of emergency medical team. We have the type 1, the type 2, and the type 3. And obviously, if you make a kind of parallel, type 1 can offer some kind of care which are usually provided to a district hospital. And when we talk about the type 2, it's a kind of care provided like by a hospital in a department or at the more intermediate level. And when we talk about, an EMT type 3, this is a kind of services provided by a tertiary hospital. So for the region here, this is, I think, a very important initiative and opportunity for reinforcing the quality of the management of of public health emergencies in Africa, notably on the component related to the clinical case management. Because you might know that usually in the region here, when an emergency occurs, we have many NGOs, and the usual ones it's NGOs like Médecins Sans Frontières or Médecins du Monde or others who used to come and to provide that care. And I think we did that analysis and we said, how can we really reinforce the agility of also our member state organization, like the countries per se, really to be able to mobilize the team to understand the concept of an emergency medical, to get a medical team to get well prepared and well trained, and then to go to address those issues. I think there are two important point which I would like to add before ending this first point. It's about first of all the characteristic here in Africa, the epidemiological characteristic in Africa. Usually, most of the emergencies, public health emergencies, occur in Africa are related to outbreaks. And when we were introduced to the emergency medical team, origins from a natural disaster, the context was a bit different. So we said, look, in Africa, we really need more emergency medical teams, which are more outbreak-oriented emergency medical teams. So that was a major shift. And I can tell you, there were a lot of, exchanges on that. But at the end, when the pandemic started, also the COVID-19 pandemic started, people understood like, yes, it's quite important to have those outbreak-oriented emergency medical teams. So today, that's not anymore a major question. So that's I think, the first point. The second point also that we tried, to put here in an emphasis on it was the need of having national emergency medical teams. Because usually when we talk about emergency medical team, it's mostly, the international teams coming from elsewhere to help a country. But we do realize, and also that's the role of our institution, of the regional office is really to be closer to the countries. We said the most important component, probably many mechanisms have been established at the global level, for mobilizing these international teams. So how can we really reinforce the first responders, so the national emergency medical teams? And for the past few years, we've been working around the development of a kind of process, for maybe a kind of certification of national teams. That work is still ongoing. And at the moment, I can tell you that, we have some countries which are quite well advanced in the process of both the international classification, which have also even finalized this kind of having some national skills and capacities, for responding to public health emergencies.
So you hit on two things that were covered in previous talks. One was the difference between an international surge response and a domestic surge response, and the need to focus on the domestic, not just the international surge response. So, and the second thing you hit on is sort of regional disparities that exist within the capacities. So in terms of real world examples, we know Senegal is working, Ethiopia is working. There's certain countries that are working on developing classified teams right now. How far along are we in the process, and where do you see us being 10 years from now in terms of how many classified teams we might have and how much regional capacity we might have?
I think there are different factors which can obviously influence such outcome. But what I can tell you at the moment, definitely, I think almost all of our countries have expressed a lot of interest around the setting the national emergency medical teams. That's for sure. And, also very recently at the regional level here, we have initiated another initiative, which is called the Search Initiative. And that Search is quite very well aligned with the AVOC initiative from the Africa CDC, which need to ensure like we have a kind of full capacity in each of the country, for really responding to public health emergencies. But again, as I'm saying, the emergency medical team is coming really to bring, the additional added value on the clinical case management, on the provision of care, going really with beds, with tents, with doctors, with medicines, with pharmacy, with toilet if needed be, to put them somewhere at the closest level of the emergency, then to provide care. And that aspect, I think, is quite very important. And since we have done a lot of awareness, sessions in different countries, in almost today, like in West Africa, in West African countries, all of the 15 countries, we have done those awareness trainings, and some of them are even hosted those international emergency medical teams. You were mentioning the case of Senegal, which were deployed like in Sierra Leone very recently for supporting the case management of a petrol tank explosion. Same thing happened earlier in 2018 in the DRC here in which is close to us here in Brazzaville. So these things are happening, and today all of the countries somehow wanted to have their own national emergency medical team. So our ambition is for these countries to have their national emergency medical team. Why not at the subnational level? But at the meantime, they have the capacity for somehow really receiving and hosting those international emergency medical teams. So having those two elements together, I think this will be something which is quite very important. Obviously, there are some challenges around the resources for getting there, because one thing is to bring the technicalities, one thing is to bring the institutional aspect, the political aspect, but the other thing is also to have the resources for the procurement of these materials, of the equipments, of the medicine, of the beds. But at the meantime, also having some kind of resources for doing some of these trainings, and then to deploy the teams on the ground.
So one of the issues that comes up when we talk about emergency medical teams, international ones, is that there isn't a lot of diversity. And so in places like Sub-Saharan Africa, you see a certain type of team coming and it's not reflective of the local community. So talk about how building this capacity would potentially impact the diversity of emergency medical teams. And do you see that actually having an impact on the quality of care that's provided in the countries when they experience disasters?
Somehow providing care, and when we take the whole quality of care, the acceptability of a care, and the technicality and the non-technicality aspect of the quality of care, From the example what I have seen so far, I mean, on that side, usually when we have international teams, and the international teams does not only mean, I mean, teams from the Western countries, it can be also a team from Senegal, which is going to another country. Obviously, there are more proximities and more similarities, but there are not too many issues or challenges. I mean, when it's properly, coordinated and organized. I think what we have seen where we have a kind of good, I mean, understanding of this exercise, definitely, I think the reception of the team is better. I mean, is really much better. During like the COVID-19, during the Delta wave, we deployed the two international teams in Uganda, and today it's Uganda who is pushing for getting the national emergency medical team. You see, that's a good example. But there have been some other emergencies, especially, let's say, like the natural disaster emergencies. We faced like 1 year ago, like in Madagascar, before people understand, I mean, the importance of the teams and getting all of the different clearances and things like that. I mean, it might have already been, somehow not that much relevant of having those international emergency medical teams. However, like recently, we sent the same team of, not the same people, but the same team from the Senegal to send them to the Gambia, I mean, for the treatment of this AKI, the acute kidney injury, I mean, emergency. I mean, we deployed that team of pediatrician and clinical doctors, and also, to provide the care, because the primary health care were really quite very well constrained, given the emergencies. They went there and they provided that care. So I think that agility and adaptability, but obviously, again, because for getting that that authorization, to receive the teams, it has to come from the Ministry of Health. And today also we have really to admit that there is always a kind of political dimension, a national dimension in the management of these public health emergencies. And before accepting the international team, it requires some kind of, diplomatic work. And this is what we are doing at our level, at the technical level, in the regional office of the WHO. But sometimes it might need a little bit more of the diplomatic side, and especially also even for the mobilization of the resources. At the moment, like the deployment of all of these teams were supported by WHO. How far maybe a country per se can just deploy their own team, in another country, I mean, by using other channels, and we can support them technically. I think all of those elements are some of the challenges that we are facing, at the moment.
So two things that came up, one was governance, one was insurance in prior conversations. From a governance model, one of the things that was discussed is that right now there isn't a regional response first, global response second mechanism within the deployment of EMTs. Do you think that having a regional mechanism so that the priority was on regional teams deploying to regional crises first would help to change the game when it comes to the EMTs in Africa? And second of all, on the insurance side, one of the points that was made was that if the WHO could insure so that the local regional EMTs didn't have to go to private insurers to insure their operations, that would encourage more responses by sub-Saharan African countries. Do you think that would be a structural game changer?
No, first of all, I think we are not talking here about somehow making some huge changes. We wanted to improve a situation, to really to complement an existing system. We have the global, and we are working really hand in hand with our global colleagues, at the headquarters, and I have to commend the really full support, I mean, to the work that we're doing. But it's just in addition to what is there, because usually today, before getting a team from Western country to come here, while maybe, it's a small emergency, but even maybe even a kind of emergency occurring in the same country. I mean, if you have a national team which can be deployed from the capital city, I mean, to go and to help in a more local, it's already, I think, a very interesting. And this is what usually happen. I mean, at the beginning of the response, that's usually what's happened. They really rely more on the local capacities. So this is something which is already happening. So it's about reinforcing that system. Now, coming to the fact of the quality assurance, we really, as WHO, quality is key for us. So this keeping, all of these criteria for quality, obviously at a certain level, it's very important. And this is what we are currently doing. We are going through a kind of, exercise for adjusting some of these criteria, for making, a team functional, to go, and which need to be somehow really ensured by the country itself per se, with the support of WHO, obviously, but to provide the care, because this is what always happens when an emergency happens. The first few days or first few hours is really somehow managed by the local capacity. So building those local capacities is something which is very important and very major, but by ensuring obviously a kind of complementarity with the global mechanism and the regional mechanism. Coming back to the regional mechanism again, it's already working. I have to say it. it's working. We've been deploying some teams. We are building a regional emergency treatment center, emergency medical team treatment center in Ethiopia. So we are really there at the moment. Obviously, expanding it and augmenting the level of functionality will be one of our objectives in the coming months and coming years. But the foundations are already there, because we really wanted to fix issues and to fix problems.
So we've been talking a lot about Blue Book responses, and there's also Red Book responses. And obviously Somalia is one of the examples that often comes up, where there's challenges with sending teams because there's armed conflict and insecurity for a long period of time. But there's other examples as well. And in a recent talk, we talked about Western Sahara, we talked about Somalia, we talked about northern Mozambique. There's places in Sub-Saharan Africa where armed conflict would pose a major challenge to EMT deployments. How are you working with the Sub-Saharan African EMT initiatives, the countries that are interested in setting up these teams, to prepare them to be able to respond in these armed conflict and other insecure environments? And how close are they to being able to do that?
Mm-hmm. No, that's a good question. I think for sure, the conflict settings, it's an environment where we are also working, and not only for the EMTs, but for all of WHO operations, because at the moment we are the one really supporting the initiative. So taking into consideration those elements is really, really important. Myself, I was in Mozambique in 2020 or 2021 in Cabo Delgado, and we used the concept of the EMTs really for providing care to the people, and it has worked, both for addressing cholera issues, but also for the provision of primary healthcare services. And we did not face that much of issues. For sure, it was in the province of Cabo Delgado, but we were in the place where normal operations were happening. Obviously, we have to follow all of the different security measures and everything, and people need to understand the scarcity of the conditions, of the working conditions in those specific areas. But what we have done at that time, it was really to focus and to rely on the local capacities. That was really the key word. So we used, we worked with our Mozambican colleagues, both from the WHO, but also from the national health authorities, to have that discussion, to find a place where we can put those teams, to provide care, definitely. So I think that work with the communities, I think today for protecting those type of teams is something which is obviously major, in addition to all other procedures which we know, for normal operations. But that work, that anchoring, the activities within, the communities, with a very good buy-in of the national authorities is something which is major.
So one of the situations that's been criticized was the response in Somalia after the tsunami, and not providing assistance with emergency medical teams in Somalia at the time. Do you think that was fair criticism? And do you think if something like that happened today in a place like Somalia was at the time the tsunami happened, that there would be a stronger response?
Oh, I'm sorry, I'm not very familiar, to the situation in Somalia, and Somalia is not covered by our region also, so I cannot comment that much about the situation for Somalia. I'm sorry for that.
Okay, so other situations in your region, have there been situations where the response that you had hoped for wasn't achieved because of the insecurity on the ground? And do you see that improving in the near future?
Oh, I think there've been a lot of work done. I mean, again, it's really about assessing that context and, setting some kind of good operations. Because the EMTs, we have not to forget that they're not coming as alone. The EMTs, they are part of an entire operation. So the quality of the operation, the environment of, an operation is something which is really important, very major, and on which I think there've been a lot of progress made today. I mean, for ensuring that those quality operations. But for sure, I mean, when we are not, we are just a health technical organization. So all other aspect of security, it's something which is managed by other organizations. But usually we really try to work hand in hand again with all of these organizations to have a kind of good quality operation, to ensure the security and the safety of the staff and also of the patients.
So during the Ebola outbreak in North Kivu, South Kivu, one of the issues was the targeting of healthcare workers. And so that was a concern. When you look at emergency medical teams and you look at the Red Book and the efforts that were made to create some guidelines on deploying into these sort of environments, do you think we're far enough with the guidelines? Do you think Red Book is a sufficient account of how you should respond in those areas? Or do you think that more work is needed to improve?
I think a manual is good. The blue book, the red book, all of those elements, they are quite very important. But applying them on the field, and if I'm not mistaken, I think the red book was published maybe in 2019 or 20, something like that. So I mean, applying that in the field and trying to improve it as much as we go is something which is important. When you are referring to the situation of Ebola in DRC, for sure, we face a lot of insecurity issues, a lot of challenges. Myself, I was there. And for sure, again, as I'm saying, it's part of an entire operation. So it's not only, I mean, the emergency medical team, we had some kind of Ebola treatment centers which were burned, which were destroyed. I mean, some campmen, some kind of, places where people were staying, I mean, were also burned. So I think really having a full package of a full perspective, a comprehensive perspective of the security for those operations and to link it with the emergency medical team. I think that's where we have to go. For sure, the Blue Book is an additional added value. I'm not very, very, very familiar with that, but as I'm saying, it's quite a new book, and at the moment we are trying really to focus a little bit more in kind of normal context of operations, but everywhere I think these contexts of security and safety, they are very important, and it's a very important component of the training and the support that we are providing to our teams in countries.
And you had mentioned earlier politics, and I wanted to ask about instrumentalization, because that's one thing the WHO has talked about in the manual, about the concern that when you deploy EMTs into an area, that some of the people on the ground, the different actors or groups, can instrumentalize and take advantage of the EMT response for their own political ends. How do you manage that as the WHO, and how do you work with the teams to make sure that when they're providing humanitarian assistance in your region, that they're not being co-opted by some of the actors on the ground for their own ends?
No, that's a good question. And from the example that we have seen so far, since I mean the EMTs were somehow deployed again as part of a bigger operation, I think all of those different conditions of neutrality, impartiality are very important. And we have seen it in North Kivu, I mean, where people were admitted into the different Ebola treatment centers without any distinction, I mean, from where they're coming from. So those principles, they are there. But again, I mean, the instrumentalization, it's about, I mean, being also for us, I mean, for the actors of the EMTs and all over the operation, it's about to be aware about those risks. And definitely there is a kind of full chain of command, and for the management of these teams and also the management of operations, which need to take those elements into consideration. But definitely it's a kind of risk which is there, but people are used to operate in those type of environment. It's just up to us, I mean, to be well prepared and training people very well. There are many other risks, like kind of, the sexual exploitation of abuses. So all of these aspects, they are important, to have that holistic point of view of the context of operation of the EMTs. It's very important, including, if you allow me, like the duration of this deployment, because the longer people stay, the longer all of these risks may happen.
So let me ask you about the perception of the outside world when there's an EMT deployment or a need for EMT deployment in Sub-Saharan Africa and specifically in your region. Do you feel like there's an overemphasis of some of the security challenges when you're talking about your region versus other regions in the world? Do you think there's more emphasis placed on the security dimension in your region? And if so, why do you think that's the case?
I don't think so. For the experiences that we had here, we did not have any major or main, or important security challenge. We have not seen that. Because again, as I'm saying, we are coming, as part of an anti-operation first. Secondly, we also come, we work quite very closely with the national health authorities. Thirdly, I think we really need to ensure also that we engage, communities as much as possible. So with all of these different, I think, elements, we are able, though, to have a good overview of the context of the challenges of the risks that we are facing and trying to address them as much as possible. But for the context that we have seen, honestly speaking, we have not seen major challenges for the deployment of the teams in Kinshasa. Yeah, it went very well. For Sierra Leone, it went very, very well. For the Gambia, same thing. Today we are using the team of Ethiopia, for the issues there inside of Ethiopia, and what is important also, we are coming as WHO to support those teams. But sometimes also, like for Ethiopia, it's a national team. So they are part of the national health authorities, the national health system. So they're going to provide care to their own populations.
And can you comment a little bit about the ongoing deployment in Malawi and how that response went and how receptive international teams were to responding there?
Look, I am not following that very closely, but I have not heard any major challenge at the moment. The team deployed there, the international team which are deployed there. Again, it's really used to happen. And usually when there is a good, process, a good explanation, a good preparation, and obviously, with a good teams, which came, it really, goes very well, and we have not really heard about any major challenge. Around during the deployment of the teams in our countries here in the region.
Okay, I want to sort of talk a little bit about the African diaspora because it's something that's being talked a lot in the African Union. So when you look at the African diaspora and the capabilities that they have in emergency medicine around the world, whether it be in Europe or the United States or South America, do you see that the African diaspora is part of the conversation about building the capacity of teams in your region, and are they being utilized fully?
Yeah, I think that could be an option, probably, because when you are talking about an African diaspora, I'm part of that probably, and I'm coming and working on that. And so it's really depends. If you have a team, organized somehow, or maybe if you have some volunteers who are wishing to come in the country for help in this thing, obviously they are very much welcome. So for us, we have a culture of openness, and but things need to be done properly. And if you have some capacities, like in a kind of specific specialty in medicine, you can come and help on that. But making a team functional, it's beyond that. It's just beyond, just coming of being a good doctor, being able to provide that care. It's beyond that. It's really about constructing all of the structure behind it. And this really require other skills, that are required for doing that. But we are very open, and I think countries usually also are very open for hosting, their own citizens living elsewhere, for coming and helping them in addressing some of these public health issues.
So on that point, the historically Black colleges and universities, Howard University has a College of Medicine. Have you done outreach to any of the HBCUs in the United States in your own work, or are you aware of it being done by others?
Not really, not that much, not as much as I can, not really. No, I can say it, no.
So when you look to the future, and we'll sort of end with your outlook, optimism, pessimism, whatever it may be. When you look to the future in the next 10 years, where do you see the emergency medical team initiative in Africa going?
No, I'm really optimistic, because I know, there is an important interest from countries for having this. And even myself, as I'm saying here, I mean, the provision of direct clinical care was just done by some of these NGOs, and the national authorities had probably hospitals, they have hospitals, but going outside of the hospital, it was not there. So that aspect of agility of outside and of coming and providing care and going back, I think this is something absolutely important, that agility. So whenever you explain very well the context, people will just buy it. Now, I mean, there are some always confusions, like around, I mean, the rapid response team or maybe the EMTs and all of those, but though this has to come with the explanation. So the engagement is there. So, and based on that, for me, I'm very optimistic because I know the needs also are here. The needs are very important. We've been able to apply the concept to different type of emergencies. Myself, I mean, I was in DRC during the Ebola outbreak in 2019 in Ecuador. I tried to conceptualize some aspect of the response by using that approach. I did the same thing for Mozambique, and we are doing the same thing. We did the same thing for the COVID-19 with the intensive care units. I mean, having some teams are capable of being deployed, and we did that in DRC. We took NGO Alima, we brought them as a kind of international EMT to provide the care in the university clinic of Kinshasa. So I think it's just that openness. The needs are there. The approach is very good, very important for solving a problem. So I'm very optimistic about it.
And do you think you have the funding to be able to achieve and implement what you hope to?
I think more resources are really needed. At the moment, it's been WHO who has been providing all of the resources for that. And unfortunately, we are not a funding organization, so we have our limitations, definitely. We wanted to showcase in some point and maybe just to address the most urgent things, but definitely having more resources, I mean, will be very, very important and very useful to be able to have this initiative up and running in the entire region.
And so what's your outlook on the funding side? Do you see opportunities for being optimistic?
They are. I think they are, because the COVID has highlighted, I mean, the importance of having this strong, I mean, response mechanism, and EMT is part of it. So we are optimistic, but definitely, I think more pushes at different level. I mean, more contribution will be very much welcome.
And between the regions, when you look at your optimism, pessimism, what regions are you most optimistic about in Sub-Saharan Africa, and which ones are you most concerned about?
No, I think there's no really, since I mean, I will not say we are starting. So far, we have seen really an interest from Southern African countries, from East African countries, Central and West Africa, everywhere. I think there is an interest. So it's just up to us, maybe in East Africa, a little bit less, but everywhere, I think we have a kind of interest, and we are working with them, and then to see, wherever, I mean, we can really bring, I mean, some changes, we can do it. But definitely go into a larger scale, and also to the speed, that will be something useful and important.
And we end with this question. If there's one thing that you could change in the EMT system that exists in the world today that would improve the response in your region of the world, what would it be and why?
I think it's probably the focus on the adaptability of it. I mean, I've been really trying to fight for that. As I was saying, having like EMTs, I mean, focusing like on outbreak, because this is really the context of our environment. Having EMTs focusing in humanitarian settings, is very important, because those are also the realities. And finally, maybe, having EMTs like also, which are more, I mean, national ones. So those are the changes that we are trying to make. So I think that's the direction where we have to go.
Well, Dr. Baldé, this has been a fascinating, wide-ranging conversation. I'm really grateful for your time. We look forward to talking to you again in the future and hearing the progress that you make.
I appreciate it. Thank you, and good afternoon there.